Hello, my name's Professor Matt Brown. I'm the Chief Scientific Officer of Genomics England. Of greater relevance to this particular study, I'm a Professor of Medicine at King's College London and a practicing rheumatologist at Guy's Hospital in London. In this video, I'll present pooled analyses of uveitis rates in patients with axial spondyloarthritis, or axSpA, treated with Bimekizumab. Author disclosure information and acknowledgements are shown here. Uveitis, specifically acute anterior uveitis, is the most common extramusculoskeletal manifestation among patients with axSpA. Among other factors, IL-17 has been implicated in the pathogenesis of uveitis and is a potential therapeutic target, although data on the effectiveness of IL-17A inhibition alone are conflicting. Bimekizumab is a monoclonal IgG1 antibody that selectively inhibits IL-17F in addition to IL-17A, which have both been implicated in the pathogenesis of axSpA and uveitis. In this video and corresponding manuscript, we present pooled analyses of the incidence of uveitis in patients with axSpA treated with Bimekizumab in phase 2b and 3 studies. Analyses included the phase 2b Agiile trial and its open label extension, and the phase 3 trials Bimobile 1, Bimobile 2, and their open label extension Bimoving. As seen in the diagram, data were pooled for patients randomized to Bimekizumab or placebo in the 16-week double-blind treatment period for Bimobile 1 and 2. Data were also separately pooled for all patients who received at least one dose of Bimekizumab in all the phase 2b and 3 trials and their open label extensions. The baseline demographics and characteristics of the axSpA study populations are shown here, mainly due to the 2-to-1 randomization ratio in Bimobile 2, in contrast to the 1-to-1 ratio in Bimobile 1. A higher proportion of patients treated with Bimekizumab had radiographic axSpA than placebo in the phase 3 study pool. HLA-B27 positivity, a key indicator associated with uveitis, was generally well matched with a slightly higher incidence in the Bimekizumab group. Patients in the Bimekizumab group had a longer time since the first axSpA symptoms compared with placebo. Finally, the rate of past history of uveitis was slightly higher in the placebo group compared with Bimekizumab. During the 16-week double-blind treatment period of the phase 3 Bimobile studies, fewer patients receiving Bimekizumab experienced uveitis compared with placebo. Incidence rates are presented throughout as exposure-adjusted incidence per 100 patient years. Incidence of uveitis was 1.8 per 100 patient years, compared with 15.4 per 100 patient years in patients randomized to Bimekizumab and placebo, respectively. A similar trend was seen in the double-blind treatment period when looking at patients split by past history of uveitis, with lower proportions of patients treated with Bimekizumab experiencing uveitis. In patients with a past history of uveitis, incidence rates in patients receiving Bimekizumab were 6.2 per 100 patient years compared with 70.4 per 100 patient years in patients receiving placebo. Overall incidence was expectedly lower in patients without a past history of uveitis, and within this subgroup it remained lower in patients receiving Bimekizumab at 1.1 per 100 patient years, compared with placebo at 3.4 per 100 patient years. In the large long-term phase 2b and 3 study pool of 848 patients treated with Bimekizumab, spanning 2,034 patient years, overall uveitis rates remained low, with an incidence of 1.2 per 100 patient years. Looking at the phase 2b and 3 study pool by past history of uveitis, the incidence of uveitis in patients treated with Bimekizumab with a past history of uveitis was 4.6 per 100 patient years. The incidence of uveitis in patients treated with Bimekizumab without a past history was much lower, at 0.6 per 100 patient years. After splitting the patients treated with Bimekizumab in the phase 2b and 3 study pool by those who did and did not have a uveitis event during the trials, the baseline demographics and characteristics were explored for certain factors associated with uveitis. Most markedly, in comparison with patients who did not have uveitis during the trials, A higher proportion of patients who experienced uveitis had a past history of uveitis. Additionally, a higher proportion of patients who had uveitis events during the trials were female, had radiographic axSpA, were HLA-B27 positive, had a longer time since first axSpA symptoms to trial baseline, had higher high-sensitivity C-reactive protein levels, and had prior TNF inhibitor exposure. The patient numbers should be noted here. Only 25 patients treated with Bimekizumab had uveitis in the trials, compared with 823 who did not. Thus, the overall differences observed here should be interpreted with caution. The results presented here are the first pooled analyses evaluating Bimekizumab, a dual IL-17A/F inhibitor, on uveitis in patients with axSpA. In the 16-week double-blind period of the Phase 3 Bimobile trials, incidence of uveitis was lower in patients randomized to Bimekizumab compared with placebo. Further, in the long-term Phase 2b and 3 study pool, the incidence of uveitis with Bimekizumab remained low. Overall, these data suggest that Bimekizumab may confer protective effects for uveitis across the full disease spectrum of axSpA.